This class, we're going to talk about the definition of epidemiology. I'm going to introduce the Socioecological Model, which you may or may not have seen before in other courses. We're going to talk about how we measure population health. And we're going to start talking about measures of morbidity and mortality, which we'll revisit again and repeatedly throughout the course. Different organizations define epidemiology differently, but a couple definitions I like are that it's the study of the distribution of disease and the factors that determine that distribution. And from the World Health Organization, epidemiology is the study of the distribution and determinants of health and disease in human populations to enable health services to be planned rationally, disease surveillance to be carried out, and preventive and control programs to be implemented and evaluated. One of the key assumptions of epidemiology is that diseases are not random. Epidemiology determines how much of a disease is out there, who has it, where it is, and the extent of the health problems it's causing in our population. By understanding the risk factors for disease and preventive factors, we can use that information to inform health interventions. Another purpose of epidemiology is to understand the natural history of a disease, which we need to know in order to design an effective intervention in order to decrease morbidity and mortality from that disease. You're probably already familiar with the public health process from other courses, but I wanted to mention it again here briefly as a reminder that in epidemiology, you're using a lot of the same processes and underlying principles as in other areas of public health. So you're always going to start with a community assessment, and you need to describe the issue using data, and you want to develop interventions based on the data. And interventions should always be community driven. So if you're working in a community that isn't a community that you're a member of, it's especially important to make sure that you aren't an outsider telling other people what they should do for their community, but instead you want to work with local leaders to ask them how you might be of assistance to their community. This is something I've seen some people do that are coming at public health from a different background that can go badly in the sense that your work won't be impactful usually if you don't have the engagement and cooperation of the local people in the community. If you're an outsider just sitting at your desk behind a computer and you're doing epidemiology, but you're not actually talking to the people impacted by the problem, it's very likely that whatever paper you publish or end product you come up with won't actually get used for anything because the people in the community might not even read it. And if they do, it might not reflect their perceived needs as a member of the community, or the intervention you come up with might not be acceptable to them for cultural reasons, etc. So I just want to remind you that you have to go back to these basic principles whenever you're doing work in epidemiology. And another underlying goal, like with other public health work, is we're trying to reduce health disparities and improve population health outcomes through health promotion, disease prevention, and systems improvements such as environmental and policy changes. So your intervention when you're doing work in epidemiology isn't necessarily like a vaccine. It could be a policy. It could be something at a different level, but the same basic objectives remain the same. Another reminder is you should always plan your evaluation before program implementation. Evaluation needs to be something that you're thinking about at the beginning, not only at the end. If you plan a program and you implement it, and then after it's already up and running, then you think, oh, how am I going to evaluate this? That's bad. You don't want to be in that position. You got to already have planned for evaluation at the beginning of the cycle. Whether you're coming from a clinical background or other background, most of us are much more familiar with how we measure the health of an individual person than how we measure the health of a population. In epidemiology, as with other disciplines within public health, our focus is on the whole population, whether that's a city, a country, or a community served by a particular health department or a community health center, which is different from medicine, nursing, and other clinical health professions where the focus is at the individual level. In healthcare, we strive to help each of our patients improve their health and meet their health-related goals. But in epidemiology, it's like we're zoomed out and looking at the whole population at the same time, and our objective is to help that whole community or population improve their health. What you see on the right is generally what we would use in medical care of an individual, whereas on the left is what we would use in public health. For an individual, we might look at metrics like the person's blood pressure. And on the population level, we might look at metrics like life expectancy, mortality rate, fertility rate. These are analogous ways of evaluating a population compared to one patient in front of you. Measuring disease impacts, the same sort of thing. For an individual, we might look at symptom progression as an example, but on the population level, we might look at years of potential life lost, quality adjusted life years, disability adjusted life years, incidence, and prevalence. These are all things we're going to be talking about in more detail later. But I just want you to be familiar with these terms in general and that they are measures of the impact on a population level, not of an individual person. And talking about evaluation again, if we're providing healthcare to patients directly, it's straightforward to figure out, did the person's blood pressure go down, or is it the same, or is it getting higher? And on the population level, we have to build in evaluations to interventions in order to determine if the outcomes were improved at the population level, if the target population is becoming healthier because of the work that we're doing. This slide presents some comparisons between health outcomes in the United States and other countries. On the left, you see infant mortality rate. You'll see the United States is way down there, and that might be surprising to some of you. With obesity prevalence, that probably won't shock many people, but you'll see yet again, we are an outlier in the United States. And life expectancy at birth, again, we're down between Chile and the Czech Republic. If you look up higher on the line, most of the European countries you might intuitively think that we would be similar to have a much higher life expectancy at birth. For example, Spain is 83 years. So if a baby is born in Spain, we would expect that baby on average to live to be 83 years old. But if a baby is born in the United States, we would expect the baby to live to be 78 approximately. This graph shows life expectancy at birth by race and Hispanic origin in the US from 2006 to 2016. You can see on the x-axis we have the year, and on the y-axis we have age. It's important to note when looking at a graph like this, see those two little diagonal lines? That tells you that there's a gap in the information that isn't displayed. So you see the age goes from 0 to 65, and then after that, it's only a 5-year difference. This graph of life expectancy at birth by race, again, shows disparities. A disparity is a difference in health outcomes between subsets of a population based on characteristics such as socioeconomic status, race, sexual orientation or gender identity, geographic location, or other factors. A central goal of public health is to reduce health disparities, but unfortunately, health disparities have persisted in the United States. The United States spends more per capita than any other country on healthcare, but our country has focused on caring for people who are already sick, for example, with hospital care, and treating conditions that have already developed rather than on preventive care, like public health typically focuses on. And that approach is much more costly for the country. More resources were diverted towards public health during the COVID-19 pandemic temporarily, but we've already seen budget cuts and programs ending that were funded during the pandemic. So there might not be that much of a lasting impact in terms of dollars allocated for public health rather than acute care in hospitals. One of the downsides of our system that spends so much of our healthcare dollars on hospital care is that healthcare overall is only about 10% of what creates a person's overall health and well-being. The social determinants of health are a framework for thinking about the things outside of the healthcare system, and the healthcare system is included within that, but all the different factors that impact health outcomes. These are a lot of the health outcomes that we're going to be talking about in this epidemiology course. Epidemiology isn't just about infectious disease, it's also the study of chronic diseases, injuries, and health-related behaviors. And it's important to remember that people don't exist in a vacuum. People interact with their immediate environment, their community, and their government. This is a version of the Socioecological Model, which is based on the theory by Uri Bronfenbrenner. And his theory argues that the environment you grow up in affects every facet of your life, and health is impacted by the interactions between all these levels of the system that surround a person. And we can't understand health behaviors without taking into account the factors external to the individual and the influence of those factors. You do not need to memorize the different levels of the system or the different components. Similar to the definition of epidemiology, this is different from different sources, but the concept here is that there's different levels around a person, and the systems that a person is living within have an influence on community health or population health. For example, the transportation system is important. If a person can't walk to school, that has an impact on their overall health. You can look at the different things on the slide and think about examples of how each of these things might have an impact on a person's health and the relationship between these different factors if you're going to try to design a program or try to study a disease in the population. Water fluoridation is a classic example of clinical observation leading to epidemiologic investigation and community-based public health intervention. Many research studies have proven the safety and benefits of fluoridated drinking water. According to the CDC, from 1966 to 1970, the average number of decayed, missing, and filled teeth among 12-year-olds in the United States declined by 68% after communities across the country started fluoridating their drinking water. In addition to reducing the pain and health problems associated with poor dentition, preventing cavities saves money for both individuals and the healthcare system overall. But unfortunately, while the majority of Americans do still support water fluoridation, it has been the target of conspiracy theories and misinformation for decades. False claims, including that fluoride is a communist brainwashing tactic, that it lowers IQ and causes cancer or Alzheimer's disease, have led some communities to ban water fluoridation. This graph shows the relationship between fluoride content in the public water supply, measured in parts per million, and dental caries or cavities experienced. There's a really clear decline in cavities as the fluoridation increases. One example of a community that banned fluoride in their drinking water is Antigua, Wisconsin. They had started fluoridating their drinking water in June of 1949. But they stopped adding fluoride in November of 1960. After 5.5 years without adequate fluoride, second-grade children had more than a 200% increase in tooth decay, fourth graders had a 70% increase, and sixth graders had a 91% increase compared to 1960. After this impact was realized, the residents of Antigua reinstituted fluoridation in October of 1965 because of the deterioration they had observed in their children's dental health. So in this example and in some other communities, it's unfortunate that the communities stopped fluoridating their water, but an interesting thing from an epidemiology perspective is they essentially did it in an experiment on themselves. This wouldn't have been ethical to do this to a population of people, but they did it to themselves. Because the same population stopped the public health intervention and then restarted it again, and we've seen this in a number of communities, this provides even stronger evidence to support the safety and benefits of water fluoridation, because we can see the change over time as the intervention was stopped and then started again. And we know that it can't be explained simply by a change in time across the whole US, because the same difference in dental caries and missing and filled teeth didn't occur simultaneously across the country. It was only in these communities that stopped fluoridating their water. We know that water fluoridation is extremely helpful for protecting against dental cavities and missing and filled teeth. But unfortunately, Alaska has a lower rate of access to fluoridated water compared to the United States overall. Looking on the left, you can see specifically the YK Delta and Norton Sound regions have higher rates of tooth loss, and this may be related to their lack of access to fluoridated drinking water. Now we're going to talk about measures of morbidity and mortality. Counts are a very simple, straightforward measure. They're just the number of cases. So counts are a measure of disease frequency. Counts are helpful with population health planning and resource allocation, but counts can't compare between groups because they aren't a rate. Rates are good for comparison between two populations or groups. Mortality rate is the number of deaths in a year divided by the population at mid-year. It can be multiplied either by 1,000 or sometimes 100,000. That isn't as important, but it's good to know that usually you're multiplying by one of those two numbers. And when you're reading a report that someone else did, usually they will make a footnote or it will be explained in a sentence. It'll say something like per 100,000, and that tells you what they multiplied by. Mortality is helpful to quantify because it shows the severity of the disease. Note that for cause-specific mortality rates, the denominator is the total population. So that includes both sick people and people without the condition. Mortality rate is a good surrogate for incidence rate for conditions when survival is low. Deaths can be thought of as incident cases because you can only die once, and everyone is at risk of dying who is in the denominator. Infant mortality rate is the number of deaths under 1 year of age during a year divided by the number of live births during that year, usually expressed as the number per 1,000 live births. Note that the denominator for infant mortality rate is live births that year. The whole population is not included in the denominator, only those at risk of infant mortality. For example, a 5-year-old in the population would not be included in the denominator of infant mortality rate because they are already over 1 year of age. Life tables can be used in survival analysis, which we'll talk about a little later on, and they are a way of showing the probability of death over time. This can be helpful for making comparisons between two different populations or between two different intervention groups. Attack rate is the number of people with an exposure who got sick divided by the total number of people with that exposure. Case fatality rate is the number of people who died during a specified period following diagnosis divided by the total number of people with the disease. Case fatality rate measures how lethal the disease is. It's the likelihood a person will die following diagnosis. The denominator is only people who have the disease, not the entire population. Pancreatic cancer would be an example of something with a high case fatality rate because the majority of people who are diagnosed with pancreatic cancer will not survive the year. Crude rates tell us the actual mortality, which is helpful because across different countries, most places are pretty good at recording deaths, but they're not as helpful for comparing two different populations as adjusted rates. With measures of morbidity and mortality, it's helpful to keep track of what's a rate versus a proportion, and that can get a little confusing. A rate is a proportion where time is always in the denominator, and rates tell us how fast a disease is occurring. The denominator is often person time in epidemiology. It could be person years, person months. You could even do person days, depending on what it is you're studying. But there's always an element of time in the denominator. A proportion is the division of two numbers where the numerator is a subset of the denominator. So that means if you're in the numerator, you have to also be in the denominator. The denominator is usually the total population. So it's both sick and well people, or people who both have or have not experienced the outcome of interest. And proportions are helpful because they tell us how much of the population is affected. To explain the concept of person time, let's say you're here in Alaska and it's winter and you're thinking about hiring someone to shovel your roof. And your neighbor says he can do it, but he's just by himself. So it's going to take him 4 hours. And he quotes your price and you think, oh, okay, maybe. But you call a local company and they say they can get it done in 1 hour because they have 4 guys who can do the work. So in this example, your one neighbor shoveling your roof for 4 hours versus the 4 guys shoveling your roof for 1 hour. Those are both the same person time. So you would likely end up paying the same amount for the labor, whether you get the one guy for 4 hours or the 4 guys for 1 hour. It's the same with a lot of studies in epidemiology. We're following people through time, and a lot of people don't stay in the study the entire length of the study. So person time is how we count each person, even though their amount of time that they actually are in the study varies, kind of like the roof shoveling example. And how we come up with person time is important to keep in mind when you're using rates, because if you're thinking about a health condition, a person who stays in a study for 20 years, let's say, might be different from a person who stays in the study for 1 year and only contributes 1 year of person time. There's different statistical methods that come into play trying to account for things like that we'll talk about later in the course. Rates tell us the risk of disease, while proportions tell us the burden of disease on a population. Note that for a proportion, such as prevalence, the total population at risk of the condition is in the denominator. There's no unit of time involved in the denominator. Here's an example of the difference between mortality rate and case fatality rate. There were 25 cases of rabies reported in the US in the past decade, and 1 teenage girl survived. So rabies is almost always fatal, which is different from measles, which usually causes moderately severe disease. You can see on the right, measles is sometimes fatal, and sometimes people have measles and they have no symptoms at all. But most of the time, people with measles are moderately severely ill. And with TB, it's tricky because a lot of people, most people, more than 60%, don't have any symptoms. So they feel fine, they look fine, but TB can be fatal. You can see it's not as common for TB to be fatal. Measles has a case fatality rate of about 10 to 15%. The case fatality rate is fatal cases among those who have the disease, and that provides an index of the deadliness of the disease. Cause-specific mortality rate is the deaths in a year from that cause divided by the total population at mid-year per either 100,000 or 1,000, depending on how you want to use that rate. The key point is that for mortality rate, the total population at mid-year is in the denominator. But for case fatality rate, it's the people who have that condition. TB mortality is fairly high because it's so much more common than rabies. Mortality rate is heavily dependent on the prevalence of a disease. And mortality rate is also heavily influenced by the age structure of the population, which we'll talk more about in a little bit. Cause-specific mortality rate for rabies in the US is very low because the numerator is deaths from rabies and the total population is in the denominator. This is in contrast to case fatality rate of almost 100% because deaths due to rabies is divided by cases of rabies for case fatality rate. Cause-specific mortality rates tell us the risk of death from that disease in our population, while case fatality tells us what proportion of cases of that disease are fatal. That's a photo I took of Arctic foxes out on St. Paul Island. In Alaska, foxes are a reservoir of rabies. You may have read about some cases up around Nome, and there was a moose that got rabies recently. It's in the animal populations here, which is different from the lower 48, where it's mostly in bats or imported dogs. We do also have bats here in Alaska. Rabies has been found from bats as well. Here's a few more measures of morbidity and mortality. Years of potential life lost is helpful for quantifying premature mortality. Disability-adjusted life years measures overall disease burden and years lost to poor health. Depression would be an example where a lot of people with depression have many years over their life that are affected by the disease, even though the mortality isn't as high compared to the people who have many years impacted by the disease. Quality adjusted life years might be used to express the impact on people's lives from a condition such as diabetes, where people are living with the disease, but their quality of life on the day-to-day may be lowered because of their disease. Life expectancy is the average number of years remaining for a person who has reached a given age. On a previous slide, I presented life expectancy at birth, and other graphs may have life expectancy at different ages. You always have to read the graph and see if it's at birth or if it's giving you a different use of life expectancy. This is some data from the Alaska Department of Public Health. On the upper right, it's showing the rate of overdose deaths per 10,000 people in the population. For Anchorage, as an example, there are 4.6 overdose deaths per 10,000 people who live in Anchorage. This would be an example of a cause-specific mortality rate, because we're not looking at all of the people who died of any cause in Anchorage. This is just showing specifically the people who died of overdose deaths. The numerator is the people who overdosed from each geographic area, and the denominator is the population living in that area during the June 2022 to May 2023 time period. Below that, we have the percentage of opioid-related overdose deaths by age and sex. In this case, the numerator is the cases of overdose death in that age range during that time period, and the denominator is all deaths from that cause during that time period. I wanted to show this example to point out that this is not a cause-specific mortality rate, because if you're looking at that pie chart, it is 100% of the deaths. This is different because a age-specific or cause-specific mortality rate would be a mortality rate that's limited to the particular age group, with the numerator as the number of deaths in that age group divided by the number of persons in that age group in the population. So again, pay attention to the differences between, does the denominator have everyone in the population in it, or is the denominator only people with a certain condition or only people who died in a certain time frame? It's always good when you're looking at these graphs to try to figure out what was the numerator, what was the denominator, to better understand what you're actually looking at with the data. This slide shows deaths ranked by number of deaths per underlying cause of death. This is from the National Vital Statistics System, which recorded 3.2 million deaths in the United States from January to December of 2022. The authors of the report noted that overall death rates and COVID-19 associated death rates were highest among non-Hispanic Black or African American persons and non-Hispanic American Indian or Alaska Native persons. This data can guide public health policies and interventions for the populations experiencing higher mortality. So tying back to what we started talking about at the beginning of this class, when we see health disparities like that, it's helpful for epidemiologists and others working in public health to use that data to then try to figure out how can we design interventions to try to reduce these disparities. This chart is an example of counts, because these are the actual number of deaths for each condition. So if you look on the x-axis, that's not a rate, it's actually showing you the number of deaths. Similar to the disparities in US data overall, Alaska data also demonstrates higher mortality rates among Alaska Native people compared to non-native people in Alaska across all causes. So you'll see on the x-axis this time, it's age-adjusted mortality rate per 100,000. And they have Alaska Native people in the lighter blue with Alaska non-native people within the state in the darker blue. So if you go back to the socioecological model, think about some possible reasons for these differences. What would be some causes for cancer deaths among Alaska Native people to be so much higher compared to other people in the state? And the same with heart disease and injuries. This is the age-adjusted all-cause mortality rate per 100,000 of the population. So again, we have Alaska Native people statewide in the lighter blue and Alaska white people in the darker blue. And this is all causes combined together. You can see if you follow the darker blue line that all-cause mortality rate is decreasing more for white people in Alaska compared to the decrease for Alaska Native people statewide. So again, we're seeing a disparity in the data between white people in Alaska and Alaska Native people. I wanted to introduce the concept of survival analysis, but you don't need to know how to calculate Kaplan-Meier curves for this course. When I was in school, we learned how to do this by hand, but nowadays everyone does this with software. I just wanted you to be familiar with the concept and to know what this is if you see a graph like this on the left. The Kaplan-Meier method calculates the probability of survival at each time when an event occurs. So if someone in the study dies, you would calculate the probability of survival at that point. And that's a little different from the life table method, which you also might see in research papers. In that one, they calculate it at regular intervals. In this example, I put 1 through 10, but for Kaplan-Meier curves, you might have kind of weird points where you're actually recalculating the probability because it's based on when an event occurred. These aren't only used for death, even though it's called survival analysis, you can actually use it for any outcome. You're just using this when you're looking for a better understanding of how many people or things will make it from the first event to the second event. Classically, the first event would be diagnosis, and the end event might be cure or death, but it doesn't have to be. You could apply this same method to almost anything. These are helpful methods for comparing two interventions, like in this example, looking at a control treatment versus an experimental treatment. And you can visually assess the shape of the curves, but it's important to know that you have to compare the curves overall, and you have to use statistics to know if there is a statistically significant difference between the two. You can't directly compare 1 point on one with 1 point on the other, because of how these were created. And you'll notice the little tick marks. Those are usually how people display when someone was lost to follow-up or disenrolled from the study. So that shows you that someone in the data set went missing at that point in time. There's some assumptions that are made when doing survival analysis like this that are important to be aware of. One of them is the assumption that anyone who dropped out of the study will have the same survival as the people who remained in the study. But this is often a questionable assumption. So if you're thinking about a long-term epidemiological study, if people drop out, it might be because of risk factors that might relate to the condition or the outcome. We'll talk about issues like that with studies more towards the end of the course. But while introducing this topic, I just wanted to go ahead and point that out, that there are some assumptions made with these methods that you have to kind of take it with a grain of salt. And it is useful for comparing two things, but it's mostly only helpful within that context. So it's good for estimating the effectiveness of a treatment or recovery rates or the probability of death over a specified time period, but you can't take data from a survival analysis or Kaplan-Meier curve and then use it like you might if this were a line graph of crude death rates, for example. It's not the same. Standardized mortality ratios are a way of expressing risk of dying from a particular cause. Both incidence of colon cancer and mortality from colon cancer is greater than twofold higher in Alaska Native people compared to the general U.S. white population. And the median age at diagnosis is 64 years for Alaska Native people, compared with 69 years for all U.S. races. So Alaska Native people are both getting colon cancer at higher rates and dying of colon cancer at higher rates, and also being diagnosed at younger ages compared to the general U.S. population. Colorectal cancer is the second leading cancer cause among Alaska Native people and accounts for 18% of cancers and 14% of cancer deaths. So this is a really significant area in need of more public health work in the state of Alaska. The difference in colorectal cancer incidence and mortality between Alaska Native people and the general U.S. population has persisted for more than 40 years. This is another example of a health disparity. Standardized mortality ratio is considered an indirect method of standardization. It allows for comparisons between groups, which is helpful in cases like this. You're going to divide the observed by the expected, and it can be expressed either as a percentage or as a ratio. If it's a ratio, if it's less than 1, then fewer deaths were observed than what would be expected. So maybe an intervention was protective and helped people survive. If it's the same, that means there was no difference. And if it's greater than 1, that means there were more deaths than expected. We can interpret this standardized mortality ratio of 2.47 by saying Alaska Native people have a 2.47 times higher risk of dying from colorectal cancer than U.S. whites. Because you'll see I included at the bottom the note that the expected is based on colorectal cancer rates in the white U.S. population. For practice questions in this course, I'm going to put up a little pause icon so you can pause the video and answer the question on your own, and then continue on at your own pace. So here's our first practice question. Health disparities are differences in health and healthcare between population groups. What was the age-specific mortality from assault for Alaska Native males aged 20 to 24 in 2021? So to answer this, we got to read what data is actually presented here. So we have non-Hispanic American Indian or Alaska Native males aged 20 to 24 years. So that's the age group that we're looking for. And we're looking for assault in this age group. So we've got accidents, intentional self-harm, assault. So the number was 32. And then if we go down here, that's where we have to find our age group again. And we're looking for males that are Alaska Native. So there we find 105,952. So our numerator is the number of deaths from assault in that age group, and our denominator is the population during that same time period. So we divide 32 by 105,952, and then we're going to multiply that by 10,000, and then we'll end up with 3 per 10,000. And that is our age-specific mortality rate from assault for Alaska Native males aged 20 to 24 in 2021. What was the age-specific mortality from suicide for Alaska Native males aged 20 to 24 in 2021? You can pause if you need to, but try to go back to the top and find which number you're going to use, and then which number you're going to use from the bottom data. So this time we're dividing 61 by the same denominator because it's the same total population in the denominator because we're looking at a mortality rate. And we multiply by 10,000 and get 6 per 10,000. The under 5 mortality rate is a common way of measuring child survival and is often used when comparing different countries. It provides the probability a child will die before reaching the age of 5 expressed per 1,000 live births. To calculate it, you divide the deaths that occurred in those aged 0 days to less than 5 years divided by the live births. So in order to be included, the people in that denominator are live births that occurred during that time period. I pulled some data from the World Bank across different countries and different years to show changes over time and how different child survival is in different countries, even to the present day. If you look carefully at these numbers, see if anything looks like a pattern to you or if there's anything that surprises you. And one question for you to answer on your own is, why do you think the number was so high in Nigeria, specifically in 1990? Looking at information like this ties back to the socioecological model and thinking about all the things external to a person that impact public health. So far, we've defined epidemiology and its objectives, introduced ways of measuring disease in populations, and discussed how this differs from measuring health outcomes in individuals, provided a brief overview of social determinants of health and the socioecological model. We discussed measures of morbidity and mortality and looked at some data from Alaska and the United States. Next lecture will be about the distribution of disease in populations, including incidence and prevalence.